This demonstration will be on the use of the periodontal probe. The periodontal probe is used to measure the depth of the gingival sulcus and detect periodontal pockets. It is used with a walking or bobbing stroke to take measurements from both buccal and lingual aspects of the tooth. To insert the probe, slide the tip below the gingival margin. The last few millimeters of the probe need to contact the tooth surface, and the working end needs to parallel the root surface being probed. As the clinician probes the mandibular teeth, note that the bobbing strokes are only about a millimeter apart. She inserts the probe at the distal line angle, walks little steps into the distal surface of the tooth, reads the probe for the distal surface, then walks along the direct buccal or lingual toward the mesial. To achieve a probe working end which is parallel to the root surface, the clinician lifts up on the fulcrum finger as she walks into the distal surface, then gradually lowers the wrist as she advances the probe along the facial or lingual surface toward the mesial. The probe tip remains subgingival throughout the stroke. The maxillary arch presents a different challenge for the clinician in accessing the maxillary molars. The clinician can overcome this by keeping the probe handle to the side of the mouth. Insert the probe at the distal line angle and walk into the distal surface until you reach the contact. Remember not to overangulate the probe. Now walk the probe along the lingual surface while pivoting the wrist to keep the working end adapted and parallel to the lingual and mesial root surfaces. Move into the mesial surface until you reach the contact. This demonstration will be on the use of the 17 Explorer. This single-ended Explorer is used to explore all surfaces of the anterior teeth and buccal and lingual surfaces of posterior teeth. The key point to use of the 17 Explorer is keeping the last millimeter of the tip adapted to the tooth surface and executing appropriate wrist movements. Use of this Explorer involves 3 wrist motions: up-down flexing, rotation or pivot, and a side-to-side motion or rocking of the wrist to create the exploratory stroke. The clinician places the tip of the 17 Explorer at the distal line angle with the tip directed toward the mesial. The dental hygienist then flexes the wrist to insert the tip of the Explorer subgingivally where it should remain during the vertical or oblique exploratory strokes. The stroke is activated with a slight side-to-side rock of the wrist and moves along the buccal or lingual surface due to the clinician's pivot of her wrist. Keep in mind that the 17 Explorer is used on buccal and lingual surfaces of posterior teeth since the shank does not have sufficient curvature to allow for interproximal adaptation. This demonstration will be on the use of the double-ended ODU Explorer and selection of the correct end. The dental hygienist will first demonstrate the use of the ODU on anterior teeth. In the anterior region, the correct end of the Explorer is determined by the handle of the instrument being parallel to the long axis of the teeth. The correct working end will hug or wrap the tooth surface. The clinician is demonstrating the correct end of the Explorer on the anterior surfaces toward the operator. The stroke begins at the midline of the tooth with the tip directed toward the interproximal surface. Strokes are vertical, overlapping, and should cover the entire tooth surface. Note the clinician's modified pen grasp on the Explorer and her use of an intraoral fulcrum on the same arch and on the incisal surface of a tooth close to the one she's exploring. Now the clinician will demonstrate exploring anterior surfaces away from the operator. If she does not change ends and holds the handle parallel to the tooth, you can see that the working end will not hug or wrap the tooth surface. The hygienist will need to change ends of the Explorer and adapt the opposite working end to hug the tooth surface. The clinician will demonstrate the use of the ODU on the mandibular anterior lingual surfaces away. As the dental hygienist moves from the maxillary arch to the mandibular arch, she must reposition the patient's head to get the chin down. The hygienist now uses the mouth mirror with a fulcrum to reflect light on the area, keep the tongue retracted, and aid in visualization of the teeth. Again, vertical strokes should be used to explore the tooth surface from the midline into the interproximal. Next, the dental hygienist will demonstrate correct end selection of the ODU for posterior teeth. Whereas the handle is the visual cue in the anterior region, the terminal shank is the visual cue in the posterior region. The correct end of the explorer is determined by placing the side of the explorer tip at the distal line angle with the tip directed into the interproximal, then checking the terminal shank for parallelism to the distal surface. If the shank is parallel, you have the correct end. If the shank comes across the buccal surface, you have the wrong end of the explorer and need to change to the other end. It is critical that you follow these steps in determining the correct end of the explorer, or you will not be successful in exploring the tooth surface. Explore the distal surface by moving from the line angle into the interproximal. When finished exploring the distal, reposition the explorer tip at the distal line angle with the tip directed mesially. This is accomplished by rolling the explorer to use the other side of the tip and pivoting the wrist to keep the tip adapted as you explore the buccal and mesial surfaces. As the clinician moves to other posterior sextants, the terminal shank continues to be the visual cue for determining the correct end. For the mandibular right lingual surfaces, the clinician will follow the same steps of adapting the explorer tip to the distal line angle, activating exploratory strokes into the distal, repositioning her fulcrum slightly on the occlusal surface while rolling the explorer between her fingers to adapt the opposite side of the tip for the lingual surface. The clinician uses indirect vision to see this area of the mouth and visualize the parallel terminal shank. If the terminal shank comes across the lingual surface, the clinician needs to change to the other end of the explorer.